Hello, everyone. I am Claire with ACC Minnesota. Thanks for joining us for tonight's lecture, Transcatheter Mitral Valve Interventions for Mitral Regurgitation. And many thanks to Dr. Vikram Sharma, a cardiology fellow at the University of Iowa and co-chair of the Iowa ACC Fit Council, who's our presenter tonight. I did just want to briefly encourage you to sign up for next month's lecture as well, happening on Tuesday, January 10th at 6 p.m. Central, same time. With that, I will turn it over to our presenter tonight, Dr. Sharma. You can take it away whenever you're ready.
Thank you so much. I am just gonna share my screen here real quick. All right, welcome everyone. Thank you for joining us for the Minnesota ACC and Iowa ACC Fit Lecture Series. My name is Vikram. I'm a fellow at the University of Iowa. I'm also the co-chair for the Iowa ACC Fit Council. I'm really delighted and excited to be here for this talk. I really had a great time putting this talk together. And I'm hoping this is going to be useful for everybody who is able to listen to this talk. And I've tried to keep a little bit for everybody, just trying to make sure there is some learning for anyone, regardless of the level of training of the fellows. So without further ado, I'm going to get started. If you have any questions for me, please put them in the chat box and I'll try to address those questions at the end of the talk. So I'm going to get started here. So firstly, I don't have any relevant lecture disclosures for this lecture. And just going over quickly through the objectives of the talk. Hopefully at the end of the talk, we'll be able to understand a little bit better the burden of mitral regurgitation as well as its clinical relevance, understand better the various etiologies of mitral regurgitation, understand the assessment of the severity of mitral regurgitation, discuss some of the important clinical trials related to transcatheter mitral valve H2H repair, and with a particular focus on criteria for patient selection. We'll also try to understand better the indications for transcatheter mitral valve replacement, as well as other transcatheter approaches to address mitral regurgitation. And in particular, we'll go over some of the emerging evidence in this field. So we'll start with a case. So we have a 74-year-old male who has a prior history of heart failure with reduced ejection fraction, secondary to ischemic cardiomyopathy, prior coronary artery disease, CRTD, and a prior AV nodal ablation for AFib. He presented to the clinic with progressive shortness of breath in the NYHA 3 class. He was on appropriate guideline-directed medical therapy for heart failure, and he had a pharmacological nuclear stress test that ruled out any reversible myocardial ischemia. So he was evaluated further using an echocardiogram, and here I have his echo images. So we can see that this gentleman has an eccentric mitral regurgitation in the setting of reduced left ventricular ejection fraction, which was measured at around 20-25%. In addition, he had moderate to severe TR. The left ventricular dimension in systole were 4.5 centimeters. So they were kind of like at the upper limit of normal for LV size or just borderline dilated, mild RV dysfunction. And the patient underwent a right heart catheterization, which showed that he had elevated right and left-sided filling pressures, but with a preserved cardiac index. So mitral regurgitation, it's the most common valvular heart disease throughout the world. And approximately 10% of people greater than age of 75 have this condition. And in the US alone, the case prevalence is estimated to be around about 4 million. And there may be 2 million or more patients who may yet be undiagnosed. So this is an unmet need as far as management of this condition. So how do people with mitral regurgitation do from a clinical standpoint? So here's some data related to survival in patients with primary or secondary mitral regurgitation. So this curve here shows us the survival in patients with severe primary mitral regurgitation. And at 5 years, their survival could be down to 60%. Here's data about secondary MR. So people with ischemic mitral regurgitation, their five-year survival may be even worse at around 40%. So clearly, this is a disease that's associated with poor survival. And considering the large number of patients who have this condition, this is definitely a condition that poses a significant burden on the population. Again, some more data related to mitral regurgitation. So functional MR in the setting of reduced EF, as we mentioned, has a survival at 5 years about 40%, and it's a little bit better in those who have preserved EF, maybe close to 60–65%. So the mitral valve anatomy, I think we're all very familiar with it, but I will mention this briefly. So the mitral valve is in close proximity to the aortic valve right behind it, separated by the aortomitral curtain. The aortic annulus is kind of like a saddle-shaped structure. It's not really circular. And then we have the anterior and posterior leaflets divided into the respective 3 segments. And at the 2 ends, we have the anterior and posterior commissure. The coronary sinus lies in close proximity to the mitral valve, and this is something that you may want to keep in mind. One of the novel devices that's being tested makes use of this anatomical proximity for a device that can be deployed in the coronary sinus to tighten up the mitral annulus, and we will talk about that towards the end of the talk. So it's really a complicated structure, and that kind of adds to the challenges in deployment of devices, as we will discuss later on. So echocardiography really is the key in assessment of mitral regurgitation, both as far as the etiology of mitral regurgitation versus the severity of mitral regurgitation. So the etiology of mitral regurgitation is very nicely summarized in the Carpentier classification. So broadly, it divides mitral regurgitation into 2 groups, primary and secondary mitral regurgitation. In patients with primary mitral regurgitation, the primary issue is with the valve leaflets, whereas in secondary MR, it's more the morphological changes in the ventricle or the atrium that is a cause of the mitral regurgitation. So mitral leaflet perforation or cleft is classified under the Carpentier type 1 lesion. Mitral valve prolapse is Carpentier type 2. This is due to excessive leaflet motion. Carpentier type 3A primary MR is related to restricted leaflet motion, both in systole and diastole, and this can be in conditions like rheumatic valve disease and mitral annular calcification. Whereas secondary MR, Carpentier type 1 is shown here. So atrial mitral regurgitation, which is really a condition that can happen due to chronic atrial fibrillation that can lead to progressive atrial dilatation, and as a result, stretching of the mitral annulus, causing a central jet of mitral regurgitation, as well as non-ischemic cardiomyopathy, again stretching that annulus while the leaflet motion position is pretty normal here. And then here is ischemic cardiomyopathy, which is Carpentier type 3B, where there is a restricted leaflet motion in systole as a result of papillary dysfunction or ischemic injury. So, primary and secondary mitral regurgitation are managed in quite different ways, and we will talk about that in the subsequent slides. So, coming back to our patient, We were talking about the etiology of his mitral regurgitation. So here is TEE images. And this gentleman clearly has lack of coaptation of his mitral valve leaflets, causing a very eccentric posterior directed mitral regurgitation. Again, here we see that the leaflets do not really coapt very well. And this was thought to be related to annular dilatation, secondary to a dilated left ventricle, as well as some restriction of the leaflet motion in the setting of ischemic cardiomyopathy. So this was thought to be a functional mitral regurgitation in the setting of his ischemic cardiomyopathy. So the next question, that comes to us is, what is the severity of this mitral regurgitation and how do we assess it? So just going over some of the basics. One of the parameters for valve regurgitation severity is the vena contracta. And what we see is that as the left ventricle squeezes the blood back into the atrium, there's a zone of flow acceleration or convergence towards the mitral valve orifice. And this eventually leads to a very narrowed portion or the neck of the regurgitant jet, which is the narrowest portion. It's also called the vena contracta. And then the jet spreads out, and this jet area can also be used to estimate the severity of mitral regurgitation. So if the jet area occupies more than 50% of the left atrial area, then that is classified as a severe MR. And a vena contracta diameter can also be used to assess the severity, and we'll talk about the different cutoffs. One board pearl for those who are sitting for echo boards, that the vena contracta should be measured in the parasternal long axis view, because the actual resolution of transthoracic echocardiogram is greater than the lateral resolution. So you might be able to get a more accurate estimate in that view. So here's our patient, and we are just measuring here the narrowest part of our mitral regurgitant jet. Here is the zone of convergence. And in our case, the vena contracta diameter is 0.72. This is once again a diagrammatic representation of the flow convergence. Basically, as blood approaches the mitral valve orifice, there is, it takes up like a hemispheric flow character, and each of these hemispheres have blood on their surface that is exactly at the same velocity. So it's called the proximal iso velocity surface area. And we can use this principle to quantify our mitral regurgitation further. So here are some of the technical aspects in when we measure it. So firstly, we adjust the eliciting velocity when we measure the mitral regurgitation severity, and you typically want to choose an eliciting velocity that's reduced to 30 to 40 centimeter per second, and importantly, in the direction of the regurgitant jet. So here we have the blood regurgitating back into the left atrium from the ventricle, and so the Nyquist limit is set to -39 in the direction of flow. And then we measure from the center of the orifice of the mitral valve to this yellow-blue interface, and that is called the Pisa radius. And then there's some formulae that can be used to calculate some of the parameters for mitral regurgitation. So these are the regurgitant flow, which is 2 pi Pisa radius square times the eliciting velocity. And then using this, we can calculate the effective regurgitant orifice area as the regurgitant flow divided by the peak of the regurgitant velocity, which can be measured using the color flow Doppler through the mitral valve. And we'll see an example of that in a second. And then the regurgitant volume can be measured using the formula EROA times the VTI of the regurgitant jet. So here are these measurements being done in our patient. So here we see that the eliciting velocity has been dropped to -30 in the direction of the regurgitant jet. And we are measuring the diameter, which is roughly 0.8 in this setting. And the eliciting velocity is going to be -30. The Pisa radius is going to be 0.8. And then the VTI can be calculated by tracing the mitral regurgitation envelope using color Doppler across the mitral valve. And this will give you both the VTI as well as the Vmax, and basically we plug that into the equations to get an EROA of 0.3 and a regurgitant volume of 33. So this is in the moderate category, and we will see how that is classified. So in some patients, it may not be possible to do the PISA method, and in those cases, we can use the regurgitant volume by the stroke volume method. And basically, the concept is that whatever is the blood flow that's coming in to the LV from the mitral valve is then ejected out from the left ventricular outflow tract. That's the LVOT stroke volume, and a part of it goes back through the mitral valve as a regurgitant volume. And so basically what it's saying is the stroke volume across the mitral valve, that's what's coming in to the LV, is equal to the regurgitant volume across the mitral valve plus the stroke volume through the LVOT. So bringing that to the other side will allow us to calculate the regurgitant volume. And this is an example of how this is measured. So using the apical four-chamber view, we can measure the annular diameter. And then by using pulse wave Doppler at the mitral valve leaflet tip, you can get the E and A waves, and then you basically just trace around it to get the mitral valve VTI. And similarly for the LVOT, we measure the LVOT diameter, and then we put a pulse wave Doppler right in the LVOT, and then trace the envelope to calculate the LVOT VTI. And so the stroke volume of the LVOT will be the cross-sectional area times the VTI, and then similarly for the stroke volume across the mitral valve, we can put in this formula to calculate our regurgitant volume. So this can then be used to calculate EROA. So there's some other parameters of regurgitation severity. So one of them is the Doppler inflow pattern across the mitral valve. So it is said that an E wave predominant filling pattern is suggestive of more severe MR, where the E by A ratio is 1.2 or more. In our case, this patient has a history of AFib, so we didn't really have the A wave here. Whereas if you had both E and A waves, and it was more of an A wave dominant flow pattern where the E by A ratio is less than 1, that would be suggestive of a more mild form of mitral regurgitation, and this has got to do with the filling pressures in the left atrium as a result of the regurgitant jet. And another parameter that is often described is the pulmonary vein systolic flow. So we know that if you put a Doppler across the pulmonary vein, there is continuous forward flow in systole and diastole, and that is also divided into S1 and S2. And then we have the diastolic flow. In this case of severe MR, what we see is a reversal of flow in this S2 phase. It may be blunted in moderate, and as it gets to severe, it may be blunted or reversed. So we are seeing here is the QRS. This is the systolic phase, and we can see the reversal of the flow in the pulmonary vein. And similarly here, there's blunting and then reversal later on. So both, showing pulmonary vein flow reversal suggestive of severe MR. So there are a number of different classification guidelines. So the 2017 AAC guidelines classify mitral regurgitation as severe. The vena contracta is more than 7. If there is pulmonary vein systolic flow reversal, large central jet or large jet area more than 50% of the LA area, the EROA being more than 40, and a PISA radius of more than 1 at an aqueous limit of 30 to 40, regurgitant volume of 60, and regurgitant fraction of more than 50. And the 2017 AAC guidelines are pretty similar, and so is the 2020 ACC-HA guidelines. So again, just going more into the classification of the severity, remember that more than 7, vena contracta, more than 40 EROA, regurgitant volume more than 60, and regurgitant fraction more than 50 would classify the MR as severe, whereas at the other spectrum, if you have EROA less than 20, regurgitant volume and regurgitant fraction less than 30, or a vena contracta width of less than 3, that would be mild, and then the rest would be moderate. So for primary mitral regurgitation, what are the treatment modalities? Really, mitral valve surgery is the mainstay of treatment for primary mitral regurgitation. That could be mitral valve repair or replacement. When do you start thinking about sending your patient for a surgery? That's when the mitral regurgitation reaches a severe status, which again, we talked about the different parameters for that. Once the patients are symptomatic, that's a clear indication for mitral valve surgery. If patients are asymptomatic, but there is evidence of a drop in EF less than 60%, or if the end systolic dimensions are more than 40, that would be another indication for mitral valve surgery. Now, what if the patients are high risk for undergoing mitral valve surgery? So in those selected patients who have a higher prohibitive surgical risk, but have an anatomy that's favorable for transcatheter intervention and the life expectancy is more than 1 year, those patients can be treated with a transcatheter H2H mitral valve repair, and that's currently has a 2A recommendation in the ACC/AHA guidelines. And probably that comes from this study. So the EVEREST-2 was one of the first few studies that really helped establish transcatheter H2H repair as an important treatment modality for patients with mitral regurgitation. So the EVEREST-1 was really a phase 1, more of a proof of concept study, but the EVEREST-2 is a study that compared surgical mitral valve repair replacement with endovascular H2H repair. And what this study showed for the first time is that using a transeptal approach to put a clip to bring together the mitral valve leaflets was associated with superior safety endpoints at 30 days with no mortality difference at 1 year. But importantly, this was less effective in reduction of MR within the first 1 year. And that was kind of the main drawback, but it's important to bear in mind that was also when this technology was just being introduced, so there wasn't as much of expertise as it is today. And so we have to take that into consideration. So this study essentially looked at degenerative mitral valve regurgitation. Those are the most common patients in the group, with about 27% still being functional. So largely primary MR, and the majority of them were in the 3+ to 4+ category. And these are the endpoints. So basically, when we look at the primary efficacy endpoint, in terms of freedom from death, from need for surgery for mitral valve dysfunction after the procedure, or grade 3+ to 4+ MR, this was really in favor of surgery, but most of it was driven by a need for a surgery for mitral valve dysfunction after the procedure. So as many as 20% of patients who were in the percutaneous repair group needed a surgical valve repair replacement after the MitraClip, whereas only 2% of patients in the surgical group needed a redo procedure. There was no difference in mortality, as we mentioned, and overall, at the end of 1 year, the number of patients, or rather the percentage of patients who were having 3+ to 4+ MR was pretty similar. And again, as you mentioned, there was no difference in death in this two groups. So really suggesting that in patients with primary mitral regurgitation who are considered high risk for surgical repair replacement could be managed with H2H mitral valve repair. So unlike primary mitral regurgitation, there isn't really a strong evidence supporting the role of mitral valve surgery for secondary MR. And currently, there is a recommendation for mitral valve surgery in patients who have severe MR, who may be having a lot of symptoms despite medical therapy, or who are undergoing surgical revascularization for coronary artery disease. You can still consider it, but again, the evidence is there, is weak. But is there really a role for edge-to-edge mitral valve repair in patients with secondary MR. So there are a couple of studies that came out in 2018 that looked at this. So the first one that I will discuss is the Mitral FR trial. So this was a multi-center trial that took place in France between 2013 to 2017. And basically, it enrolled patients who had severe secondary mitral regurgitation, which was defined at that time by the ESC 2012 guidelines. And we see those cutoffs were a little bit different from the ESC 2017 criteria. And this defined severe MR as patients who have a regurgitant volume more than 30 or a regurgitant orifice area more than 20, which now is changed to 30. So probably patients with slightly less severe MR were enrolled in this study is one of the thoughts about this. And then the inclusion criteria included patients who had a LVEF of 15 to 40%, again, on the lower spectrum, and the patient need to have NYHA2 or worse chronic heart failure symptoms. So what we saw in this study is that there was no difference in the control versus the intervention group at 12 months. Here are the statistics related to that. So there wasn't any difference in death from any cause, cardiovascular death, hospitalization, and the composite of MACE. And there were a few reasons that were proposed for why this may have been a negative study. Firstly, there was a high rate of residual 2+ or greater MR, roughly 24%. In both these groups, the mortality was high. If you look at the cardiovascular and all-cause mortality, it was in the region of 20-25%, which was high in both these populations, suggesting that this was perhaps a sicker patient population that presented too late in the course of the cardiomyopathy. And it's possible that in these patients, the severe cardiomyopathy was perhaps the primary driver of outcomes. An additional factor here was that in the trial, there was no upper limit set for the LV dimensions. And the thought is that this could have led to patients who had more severely dilated left ventricles being included, perhaps again at the later spectrum of the course of the cardiomyopathy, and that could have affected the outcome. And as I mentioned, according to the 2012 ESC guidelines, it perhaps included patients that had a less severe MR. In contrast, another study that came at the same time was the COAP trial. This was also a multi-center trial that took place across the US and Canada, multiple centers, and it enrolled patients who had heart failure, NYHA2 or more, with moderate to severe or severe mitral regurgitation in the setting of reduced LV function. And the patients were randomly assigned to transcatheter mitral valve repair plus medical therapy versus medical therapy alone. And as I mentioned, it included patients who had ischemic or non-ischemic cardiomyopathy, but with a reduced EF. So here the cutoff was 20 to 50%, which was slightly higher than that was used in the Mitral FR trial. Again, moderate to severe and severe secondary mitral regurgitation using the 2017, the criteria that were prevalent at that time and that used a slightly higher cutoff. And these patients, again, had to be symptomatic despite use of guideline-directed medical therapy and or cardiac resynchronization therapy. So in this trial, we did see a significant difference in mortality at 24 months, and this is also present at 12 months, and also a big difference in hospitalization for heart failure. So these results are quite different from what was seen in the Mitral FR trial. And again, we talk about the cumulative, now, slightly longer follow-up up to 3 years. We see those results were still maintained in terms of the all-cause mortality, as well as the cumulative heart failure hospitalization. And then when we look at the device-related complications, actually the complication rates were very low, 1.4%, and there were no additional complications, device-related complications beyond the first 30 days. But there were, patients who had progressive heart failure up to 36 months, and some of them needed a heart transplantation. So really, from a procedural standpoint, the complication rates were really low in this study. So What was different in the two studies that could explain the big difference in the outcome? So we talked about the difference in the cutoffs for mitral regurgitation. So the ROA cutoff in the MITRA FR was 20, where it was 30 in the COAP trial, and also the regurgitation volume was greater than 30 compared to greater than 45. So a more severe mitral regurgitation spectrum here. Also, as I mentioned, there was no upper cutoff for the LV end systolic diameter in the MITRA FR trial, whereas in the COAP trial, there was a cutoff of less than 70. So preventing patients who had severely dilated left ventricles from being enrolled in that study. And then we talked about the LVEF cutoff being slightly on the lower spectrum, between 15 to 40% in the MITRA FR, and between 20 to 50% in the COAP trial. So those might explain some of the differences. And then there were also other differences in the way the medical therapy was managed in the two groups, those were the main reasons for the difference. So based on this, the current understanding is that the patients who benefit most from the mitral valve H2H repair are those who have at least moderate to severe mitral regurgitation defined by the COAP criteria, which is an EROA more than 30 and regurgitation volume more than 45, and patients who have mild to moderate LV systolic dysfunction. So the cutoff they use is more than 20%, but below 70 millimeters as far as the end systolic dimensions of the LV are concerned. So definitely once you have more severe spectrum of LV dysfunction or LV dilatation and more mild to moderate MR, it doesn't really work. So the current guidelines, which are the 2020 ACC-AHA guidelines, recommend that transcatheter H2H mitral valve repair can be considered in patients who have moderate to severe MR, who have persistent symptoms despite optimal guideline-directed medical therapy, but also mentioned this in patients who have preserved EF but have severe symptoms, or just have symptoms that are not suitable for a transcatheter H2H repair. Those can be still considered for mitral valve surgery, but that's a 2B recommendation compared to a 2A recommendation. So coming back to our patient, so here we see the mitral clip being deployed with an excellent result. We see the MR being reduced to trace to mild in this case, and there were no procedure complications. The patient was seen at 1 year and doing a lot better, had a lot more energy. The NYHA status had improved to class 2. There were no hospitalizations, and actually there was some improvement in the EF compared to prior. So really good result, highlighting that these patients can benefit from transcatheter H2H repair. So just a timeline of some of the important developments in this field that we've gone over. So the Everest phase 1 study really came out in 2005, and it was a while before the Everest 2 results were published. In 2013, FDA approved mitral clip for mitral regurgitation, which is primary in patients who had a prohibitive surgical risk. And then subsequently in 2018 is when the COAP MITRA FR trials were published. And in 2019, the mitral clip was approved for patients with moderate to severe secondary MR who remain symptomatic despite optimal medical therapy. Changing gears a little bit here. So we know that we cannot treat all our patients with transcatheter H2H repair. There's some patients who will not be appropriate. So here is a case that illustrates an example. So here's a 74-year-old patient, has a history of pulmonary hypertension, enlarged right ventricle, decreased right ventricular systolic function, moderate to severe TR, coronary artery disease, prior CABG, multiple PCIs, paroxysmal AFib, who have a known history of mitral valve insufficiency, had a bioprosthetic mitral valve replacement with a St. Jude valve in 2005, and now presenting to the hospital with progressive shortness of breath. Patient was admitted with acute heart failure exacerbation, bilateral pleural effusions, and an echocardiogram was performed, which is shown here. So basically, this patient is slightly different, of course, from the one that we discussed earlier. So this patient had a prior bioprosthetic valve in place. There was a prolapse of the anterolateral bioprosthetic leaflet, and there was lack of coaptation, leading to an eccentric posterior direction jet of mitral regurgitation. We see here flow reversal in the pulmonary veins, suggesting a severe mitral regurgitation. And here again, we see kind of this prolapsed segment of the anterolateral bioprosthetic valve leaflet, which is the mechanism behind this mitral regurgitation. So this patient, of course, cannot be treated through an edge-to-edge mitral valve repair because they didn't really look at this patient population. But thankfully, there are a range of newer transcatheter mitral valve devices that may offer a solution to some of these patients who we cannot treat with edge-to-edge repair. So today I'm going to mostly focus my talk in this next part on mitral valve replacement, because it's a very valuable tool for us to treat some of the patients that we cannot treat with edge-to-edge repair. And we'll also briefly mention about some newer devices or newer approaches to annuloplasty. And there's some other experimental approaches that I am not really going to focus on today. Who are the patients who we cannot treat with transcatheter edge-to-edge repair? So these are patients who have commissural mitral regurgitation or a broad jet of MR. Those would be better treated with a transcatheter mitral valve repair replacement as compared to those who have a central MR jet. Now, one important consideration is mitral valve area. So you need an adequate mitral valve area to be able to perform a transcatheter edge-to-edge repair because of the risk of mitral stenosis after the procedure if the valve area is less than 4. So if you have a small mitral valve area, that might be better treated with a mitral valve replacement through a transcatheter approach. Other things are leaflet calcification in the grasping zone, or short posterior mitral valve leaflet less than 7 millimeter would make it more favorable to do a TMVR. Other things such as the flail gap, the coaptation gap, those factors can tip the balance more in favor of a transcatheter mitral valve replacement rather than an edge-to-edge repair. Now, there's some things which are known complications or issues in transcatheter mitral valve replacement, and we'll talk about that a little bit more in the latter part of this talk. These include patients who have a high risk of LVOT obstruction or asymmetrical mitral annular calcification. Those are not favorable for transcatheter mitral valve replacement. So, this basically suggests that there's some patients who may not be feasible for transcatheter edge-to-edge repair, and in those patients, a transcatheter mitral valve replacement may be better tolerated than a surgical procedure. This is what we will talk about in the next part of this talk. So there are several challenges which are associated with the transcatheter mitral valve replacement. The mitral valve has a complex structure, and that's made more complex by the presence of a complicated subvalvular apparatus. We talked earlier how the annulus is saddle-shaped, and there is really a wide variety of mitral valve pathologies. So these demand a diverse range of approaches to treat. There is a close proximity to the aortic valve and the left ventricular outflow tract. This is a challenge, in particular. Mitral valve replacement offers a risk of left ventricular outflow tract obstruction. There are a couple of different approaches that are possible, transapical and transseptal, and currently there isn't really a clear consensus as to a standardized approach. And then one of the biggest hindrance is also mitral annular calcification. This in particular puts patients at the risk of paravalvular leak as well as device migration or embolization. There is an associated risk of valve thrombosis. Hence, patients have a need for anticoagulation, at least for a short period of time perioperatively, which may not be possible in some patients who have a higher bleeding risk. So bearing those in mind, there are a wide range of devices that have been made and put to use. I'll focus on some of the ones that are gaining popularity. So there's the Intrepid device, which is basically a self-expanding device that's placed through an apical approach. The Tendyne is another self-expanding device that is also placed through an apical approach. As compared to that, the Sapien valve is basically a balloon expandable valve that is placed using a transeptal puncture. And one of the unique valves is the Alta valve. Basically, it has this spherical anchor that basically fits into the left atrium. So this valve is anchored in the left atrium rather than at the level of the mitral annulus, which is something pretty unique about this. And then there's the Evoke, which is a self-expanding valve. So there are other valves as well which are listed here. So really one of the earliest studies that looked at the safety and efficacy of a transcatheter valve implantation was this study that was published in 2017 that used the balloon expandable Sapien valves for valve replacement. And this was in patients who had a significant bioprosthetic mitral valve dysfunction or an annuloplasty repair dysfunction leading to either stenosis, regurgitation, or both, or patients who had mitral stenosis due to MAC. And these were all patients who had a high risk of sternotomy and redo valve replacement. So those were the patients that were evaluated in this study. And basically, it looked at three major groups. So transcatheter mitral valve in valve replacement, transcatheter valve in ring, and transcatheter mitral valve in MAC. Majority of the patients in this study were valve in valve. The procedural success was really high, like 97%, but in valve in MAC, the procedural success rate was down to 75%. There was a high procedural mortality in the valve in MAC population, 17%. There's also a greater risk of bleeding in these patients. Lot more chances of left ventricular outflow obstruction in patients undergoing valve in ring or valve in MAC approach. And a large number of these patients also needed a second valve. So, but if you look at just the valve in valve population, the 30-day survival was 95%, as you mentioned, with a great amount of procedural success. And that is very promising. Here, we are comparing the outcomes in valve versus valve in ring or MAC, and we can see the patients who had a valve in valve procedure did pretty well in comparison to the valve in ring or valve in MAC patients. So really, for the first time, showing that maybe there may be a viable option for patients, at least with a failed bioprosthetic valve, who can have a valve in valve transcatheter intervention if they were high risk for redo surgery. So the main points from this study were that for a failed mitral valve prosthesis, transvenous transeptal balloon expandable valve implantation had a 97% procedural success, 95% 30-day survival, and an 86% one-day survival with durable prosthetic function at 1 year follow-up. The procedure was less successful in patients who had a failed annuloplasty ring and severe MAC, but this was still feasible. There was an associated risk of LV outflow tract obstruction, need for a second valve or a subsequent surgical valve intervention. In patients who did have an initially successful procedure, 1 year prosthetic function was favorable. And there was a 2% incidence of prosthetic valve thrombosis in this patient population, despite being on therapeutic anticoagulation, supporting the current recommendation for systemic anticoagulation in these patients. And some of the factors that were associated with left ventricular outflow tract obstruction were a higher LVEF and a smaller cavity size. So this was followed by some additional data. So here is data from the TVT registry that was published in 2020. Again, looking at mitral valve in valve, mitral valve in ring versus valve in MAC, transcatheter mitral valve replacements. And we can see that the valve in valve procedure has a low in-hospital and 30-day mortality, whereas in patients with MAC, that mortality is pretty high. But of patients who did survive this, there was a significant improvement in NYHA status, with majority of the patients being either class 1 or class 2 at 30-day follow-up. There was subsequent data from the mitral trial, which also looked at transcatheter mitral valve in valve in either a failed or dysfunctional prior bioprosthesis. So here also they used the SAPIEN XT or the SAPIEN 3 valves. These are patients who had severe mitral regurgitation or stenosis due to a failed surgical bioprosthesis. And here is the data for their 30-day and 1-year outcomes. So 30-day mortality was pretty low, 3.3%, and there were no additional death at 1 year. And then here we see, as compared to the pre-valve implantation, there was a significant improvement in NYHA class at 30 days, and this was sustained at 1 year. And there was also improvement in the 6-minute walk. So this was really very promising. And so, around this time, the FDA approved the SAPIEN 3 valve for a valve-in-valve mitral replacement in those patients who had a high surgical risk for a redo mitral valve replacement. Here are the outcomes for those patients who underwent a valve-in-ring procedure. And we know that these patients don't do as well as valve-in-valve patients. So 30-day mortality was higher at 6.7%, and 1-year mortality is really much higher, 23.3%. But again, patients who did survive did have improvement in NYHA class progressively at 30 days and 1 year. And so this is possible, but again, associated with high mortality and high rate of complications. So to summarize some of the data related to a valve-in-ring transcatheter mitral valve replacement, the technical success in the TVT registry was 83%, and 30-day mortality was roughly 11%. In the prospective mitral trial that we just looked at, the 30-day all-cause mortality was lower at 6%. Technical success was lower in this population, mainly due to the need for a second valve, again, related to the technical difficulty of doing a valve in ring. And important to know that only semi-rigid complete rings are considered optimal for this approach, because they can appropriately circularize around the implanted valve, and this provide a sufficient force for valve anchoring. So that's something important to bear in mind. And so the FDA approved the SAPIEN 3 valve in 2021 in the US for a valve-in-ring approach, but bear in mind that there are some challenges that still remain for this approach. So what are the important things about the procedure planning? So first of all, we know the most favorable outcome is with patients undergoing mitral valve-in-valve procedures, but they do have a risk of LVOT obstruction and a residual paravalvular regurgitation. We can assess this risk by looking at certain factors like the CT, predicted neo-LVOT area, that we'll talk about shortly. We talked about the valve-in-valve valve-in-mitral annual calcification. Those patients have a significant risk of residual regurgitation, embolization, as well as LVOT obstruction. And then again, looking at the distribution of MAC or the predicted neo-LVOT area can help determine if patients are suitable for that. And then for a valve-in-ring approach, you have to exclude really ring dehiscence, which would be a contraindication, and then also the predicted neo-LVOT area. So there aren't really yet, we haven't really talked about patients who have native mitral valve regurgitation. are there any transcatheter mitral valve options for that? So two in particular, the Intrepid and the Tendyne devices have been tested in this patient population with native valve regurgitation who are too high risk for surgery. And I'll just mention some of the studies related to these devices. So first one I will talk about is the Intrepid device. So this is data from the Intrepid global pilot study. Here is the Intrepid device. So basically, it's a self-expanding nitinol valve, and basically this is deployed through a transapical approach. It has an atrial brim, which kind of overhangs into the atrium, and basically it has an outer stent frame, which really allows fixation of the mitral valve to the annulus. And in this patient's experience from about 50 patients was shared. There was successful implantation in 96% of the patients. The key inclusion criteria were patients with symptomatic severe MR, who had no or minimal mitral valve calcification, who had LVEF more than 20%, and those were high or extreme risk for open mitral valve surgery. The 30-day mortality here was 14%. There weren't any patients with disabling strokes or repeat interventions. And basically here we see the reduction in MR to either no or mild MR in majority of the patients at 30 days and on their last follow-up, which is a median of 173. It's really good result in terms of reduction in MR severity, which was promising. And then here we talk about the Tendyne heart valve. Again, this is a self-expanding valve that's deployed through a transapical approach. It has this unique pad that basically allows anchoring of the device at the apex. It also has a atrial sealing cuff that prevents paravalvular leak. We talked about this apical pad that tethers the valve to the apex. So basically, in Europe, this was the first device that was commercially available, and there's currently a trial that's going on that hopefully will provide more data on its use. In the United States, there were some studies published looking at the safety and efficacy of the Tendyne valve. So the first one here from Dr. Saraja and colleagues basically looked at patients who underwent a transcatheter mitral valve replacement with the Tendyne valve. The 30-day mortality was 6%. 1-year mortality was a little bit higher, 26%. But amongst those survivors, 88.5% had just mild or no symptoms. And we can see that majority of the patients had none or trivial MR at pre-discharge, and that effect was pretty much maintained up to 12 months. We can also see that there was a significant improvement in the functional class of these patients as well that was maintained up to 12 months. So again, some promising data here. And they also published a small series of about 9 patients who had the Tendyne prosthesis that was deployed in patients who had severe mitral annular calcification. And there were no procedural deaths. There was one patient who had a left ventricular outflow tract obstruction, and this was successfully treated with alcohol septal ablation. There was one cardiac death, one non-cardiac death, so 2 patients died. There was no prostatic dysfunction, and there was a clinical improvement with mild or no symptoms in all patients who were alive at the end of follow-up. So there's definitely a room for improvement, but this was definitely promising as far as potential for transcatheter mitral valve replacement in patients even with native valve, which hopefully might become FDA approved in the future. So briefly, just in the next few slides, I will talk about the risk of complications. So here is a CT scan showing the mitral valve in close proximity to the LVOT. So when we place a mitral valve, it basically pushes the anterior mitral valve leaflet towards the LVOT, creating what is called a neo-LVOT. And basically, this is illustrated here in this graph. So here's a mitral valve prosthesis, pushing the anterior mitral leaflet close to the LVOT, particularly in those patients who might have some basal septal hypertrophy. You can have a small LVOT area. So in particular, a neo LVOT of less than 1.7 square centimeter, which is measured in mid to end systole, is considered high risk for subsequent LV outflow tract obstruction. This can be estimated using a CT-based simulation and is recommended in all patients undergoing such mitral valve implantation through a transcatheter approach. Secondly, we can do a procedure called as Lampoon, which is actually kind of similar to the Basilica procedure that's done in patients undergoing a valve-in-valve TAVR, where you lacerate the mitral valve leaflet to reduce the risk of LVOT obstruction. A second approach, as I mentioned, you can ablate the basal part of the septum, thereby increasing your neo LVOT area. So here is an example of a patient who had their neo LVOT area increased to 416 millimeters squared using this alcohol septal ablation approach as compared to a pre of around 160. So a couple of strategies that can be used to tackle the risk of left ventricular outflow tract obstruction in these patients, something to bear in mind. We mentioned that there are a number of other technologies or approaches that are being tested currently. So I'm not going to go into a lot of detail for the evidence around these, but basically there are a number of different annuloplasty systems. So AccuCinch and Cardioband essentially have anchors that help tighten the annulus. Iris has basically a kind of a framework of anchors that do the same thing. I mentioned the Carillon mitral contour system makes use of the close proximity of the coronary sinus to the mitral valve. So these anchors can be put into the coronary sinus, and thereby hopefully they can reduce the annular size and thereby reduce the severity of mitral regurgitation. And the AMEN is a similar system that's placed transapically. So all these basically work by reducing the annular dimensions and thereby help to reduce the severity of mitral regurgitation. So going back to our patient, we basically proceeded with a transcatheter mitral valve replacement using a SAPIEN valve. And this was done through a transeptal approach. So here we see the transeptal needle kind of going through the interatrial septum. Here is the valve basically being advanced across the mitral valve. Here we see the fluoroscopy image of a valve without the balloon expansion. And then here it is the deployed valve showing a great result and basically trace MR at the end of the procedure. And here we see a normal functioning of the new valve that was placed. So patient did well, and a 6-month follow-up has had no complications and significant improvement. And basically, this patient was dealt with through a different approach. So in summary, just going over the timeline of some of the important developments that we mentioned in this talk. So just putting this side by side with the transcatheter edge-to-edge repair data. So in 2005, we just really had the first phase 1 study for transcatheter edge-to-edge mitral valve repair. A few years later, we had the Everest-2 trial that compared transcatheter edge-to-edge repair and mitral regurgitation with surgical mitral valve replacement in high-risk patients. In 2013, we had the FDA approval of the MitraClip for primary mitral regurgitation in those patients who had a prohibitive surgical risk. Subsequently, we had data for the balloon expanding transcatheter mitral valve implantation in patients with a failed mitral bioprosthesis or failed ring annuloplasty or mitral annular calcification. In 2017, subsequently, the FDA approved SAPIEN 3 for valve-in-valve transcatheter mitral valve replacement in patients who had a high surgical risk. In 2018, we had the COAPT, MITRA FR, and the INTREPID results published. 2019 is when the MitraClip was approved by the FDA for moderate to severe secondary MR in patients with symptoms despite optimum medical therapy. Subsequently, we had data related to the use of Tendyne and other transcatheter mitral valves in the native valve. In 2021, we had the FDA approval for SAPIEN 3 to be used for valve in ring TMVR. And potential future directions, there may be in the future an expectation for FDA approval for TMVR devices and native valves, as well as some of the other devices we mentioned, including some of the annuloplasty devices. And that might give us more options to treat this patient population. So that's the end of my talk. I want to sincerely thank the Minnesota chapter for giving me the opportunity to present here today. I want to also thank the University of Iowa Structural Intervention team, who basically did the procedures that I discussed here, and also provided me with some significant insight that was helpful in the talk, and also to the ACC Iowa chapter FIT Council for again giving me this opportunity to talk here today. So with that, that's the end of my talk, and I can see if there are any questions.
Thank you, Dr. Sharma. I don't see any questions right now, but if you have any questions, please add them pretty quickly. And in the meantime, I'll pop in the chat the link to register for next month's lecture. Okay, I don't see any questions, but again, thank you so much, Dr. Sharma, for sharing your expertise with us today, and have a great evening.
Thank you so much for again inviting me, and thank you everyone for attending. Have a good evening.